If you have been diagnosed with endometriosis, please refer to the NICE guidelines for help and advice on this topic. A rare cause of fertility problems is adhesions. These are essentially tissues that have joined together in the womb, which causes a woman's period to stop. If this happens, you may be offered a minor procedure to clear the adhesions, which may help your periods to start again and so improve your chances of getting pregnant. Now let's discuss unexplained infertility. So if you have unexplained infertility, it means that no reason has been found for your fertility problems. You may feel anxious to try fertility drugs, but you should not be offered clomiphene citrate or other fertility drugs taken by the mouth because it has not been found to improve the chance of pregnancy compared with trying for a baby naturally. If you have been trying to conceive through regular unprotected sexual intercourse for a total of 2 years, and this can include 1 year of trying before you've had your fertility tests, and have not become pregnant, you may be offered IVF. When it comes to HIV, hepatitis B and hepatitis C patients, if you or your partner is known to have either of these diseases, you should receive specialist help and advice to conceive. For a man who is HIV positive, it is possible for you to conceive with a HIV negative woman through unprotected sexual intercourse under specific circumstances. So if you're taking HIV drugs known as HAART, which stands for highly active antiretroviral therapy, the risk of infection during intercourse is minimal as long as all of these conditions are met, including if you're taking your HIV drugs correctly. If blood tests show that the virus has been undetected in your body for the past 6 months, this is called having an undetectable viral load. If you have no other infections, and also if unprotected sexual intercourse is limited to the time of the month where the woman is ovulating, your doctors can always help you determine the best days to try. It's very important to still use protection during the times when you're not trying to conceive in order to minimize the risk of passing on the infection. If the virus is detected in your blood, you are not taking your HIV drugs correctly, or you and your partner do not want to have unprotected sexual intercourse, you may instead be offered sperm washing. This involves separating the sperm from the semen, which reduces the chances of transmission because HIV is carried by the semen. The sperm is then used for the intrauterine insemination or the IVF procedure that follows afterwards. If you can meet all of the conditions in the list above, sperm washing may not reduce the risk of HIV infection any further. It's never possible to guarantee that the sperm is completely free from the virus. Sperm washing may also reduce the likelihood of becoming pregnant compared with natural conception. Also, if you do meet all the conditions in the list above, NICE does not recommend also using pre-exposure prophylaxis, in which a HIV negative woman takes antiretroviral drugs to reduce her risk of getting the virus before having unprotected intercourse with a man who is HIV positive. This is because it has not been found to reduce the risk of infection any further. But before you make any decisions about trying to conceive, you should be offered the chance to have a discussion with both a HIV specialist and a fertility specialist. When it comes to hepatitis B, which is a virus that can infect and damage your liver, if one of you has hepatitis B, your partner should be offered hepatitis B vaccination because the illness can be passed on through unprotected sexual intercourse. For men with hepatitis B, you should not be offered sperm washing before having fertility treatment. Hepatitis C is another type of hepatitis virus which also infects the liver. In couples where the man has hepatitis C and the woman does not, the risk of infecting your partner during unprotected sexual intercourse is thought to be low. However, you should have the opportunity to talk to both a fertility specialist and a hepatitis specialist before you make any decisions about trying to conceive. For men, this should include talking about treatment options to eliminate the virus from your body. Assisted reproduction is a type of fertility treatment. So it's the name given to treatments that can help you get pregnant without you having sexual intercourse. There are a variety of treatments, and what is suitable for you will depend on your own circumstances. The options include intrauterine insemination, IUI, in vitro fertilisation, IVF, IVF with intracytoplasmic sperm injection, ICSI, and the use of donor sperm, so donor insemination, or eggs, called egg donation. These treatments are described in the sections that follow. Other methods of assisted reproduction called gamete intrafallopian transfer, GIFT, or zygote intrafallopian transfer, ZIFT, are not recommended. Certain forms of assisted reproduction are regulated by law, and their use is controlled by the Human Fertilisation and Embryology Authority. Intrauterine insemination comes under assisted reproductive technology, which is a treatment for infertility. So intrauterine insemination is a type of artificial insemination in which sperm is placed inside the womb. Another type of artificial insemination is intracervical insemination, where sperm is placed at the cervix, which is the neck of the womb. If you are using ICI, which is intracervical insemination, you have a higher chance of pregnancy if you use fresh sperm. This basically means a sperm that has not previously been frozen. However, IUI gives you a higher chance of pregnancy than ICI, even if previously frozen, then thawed sperm is used. You may be offered IUI if you and your partner are unable to, or find it very difficult to, have sexual intercourse, for example, because of a physical disability. You may also be offered IUI if you have a condition, such as viral infections, that can be sexually transmitted. That means you need specific help to conceive. For example, if you're having sperm washing before conception can take place. Another reason you may be offered IUI is if you are in a same-sex relationship and have not become pregnant after 6 cycles of artificial insemination. You should be offered unstimulated IUI, which means that you are not given fertility drugs to stimulate your ovaries during the treatment. You should have your insemination timed around ovulation to give you the best chance of success. If you don't become pregnant after 6 cycles of IUI, you should be offered fertility tests. And if these test results are normal, you should be offered another 6 cycles of IUI before other treatments such as IVF are considered. There are some cases where intrauterine insemination should not be offered. You and your partner shouldn't be offered IUI in the following circumstances because it hasn't been found to increase your chances of getting pregnant. And these include cases of unexplained infertility, a low sperm count or poor quality sperm, or in patients with mild endometriosis. In these circumstances, you should be advised to keep trying to conceive through regular unprotected sexual intercourse for a total of 2 years, which may include 1 year of trying before you've had your fertility tests. After this time, you may be offered IVF. So when shouldn't intrauterine insemination be offered? You and your partner should not usually be offered IUI in the following circumstances because it hasn't been found to increase your chances of getting pregnant. So in cases of unexplained infertility, if you have a low sperm count or poor quality sperm, or if you suffer from mild endometriosis. In these circumstances, you should be advised to keep trying to conceive through regular unprotected sexual intercourse for a total of 2 years, and this may include 1 year of trying before you've had your fertility tests. However, after this time, you may be offered IVF. For a lot of couples with fertility problems, in vitro fertilisation may be the perfect option in order to overcome their infertility. So what is a full cycle of IVF? A full cycle of IVF is one in which 1 or 2 embryos produced from eggs collected after ovarian stimulation are replaced into the womb as fresh embryos, with any remaining good quality embryos frozen for use later. When these frozen embryos are used later, this is still considered to be part of the same cycle. You may be questioning what your chances of having a baby with IVF are. For women, the chance of success with IVF depends partly on your age. The older you are, the less likely you are to have a baby. IVF is also more effective for women who have been pregnant or have had a baby before. The chance of having a baby fall with the number of unsuccessful cycles of IVF you've already had. There are also some lifestyle factors involved with the success rates of IVF. So for women, the chance of success with IVF depends partly on if you or your partner drink more than 1 unit of alcohol a day, which will lessen your chance of success through IVF. This may also be the case if you or your partner smoke. And treatment with IVF is also more effective for women who have a BMI between 19 and 30. For women, drinking caffeinated drinks also lessens your chance of success through IVF. If IVF is a possible treatment for you, your doctor should first discuss with you the risks and benefits of IVF treatment in line with the code of practice produced by the HFEA. For women aged under 40 years, you should be offered 3 full cycles of IVF if you have been trying to get pregnant through regular unprotected sexual intercourse for a total of 2 years, or if you are using artificial insemination to conceive and you have not become pregnant after 12 cycles, at least 6 of these cycles should have been using intrauterine insemination. However, if your tests show that there appears to be no chance of you conceiving naturally and that IVF is the only treatment that is likely to help, you should be referred straight away for IVF. Any previous cycles of IVF you have had, including cycles that you have paid for yourself, will count towards the 3 cycles you should be offered by the NHS. This is because the chances of having a baby fall with the number of unsuccessful cycles of IVF. Your doctor should also take into account how you responded to any previous IVF treatment and what the outcome was when deciding how effective and safe further IVF would be for you. If you turn 40 during an IVF cycle, you can finish the current full cycle, but you should not be offered further cycles. You will still be able to have any frozen embryos transferred from your most recent episode of ovarian stimulation, since these do count as part of the same full cycle. If you happen to be between the ages of 40 to 42 years old and are seeking IVF treatment, you should be offered 1 full cycle of IVF if all of the following apply to you. So if you have been trying to get pregnant through regular unprotected sexual intercourse for a total of 2 years, or if you have not become pregnant after 12 cycles of artificial insemination, at least 6 of these cycles should have been through intrauterine insemination. If you're a woman aged between 40 to 42 years, you should be offered 1 full cycle of IVF if all of the following apply, including also if you have never had IVF treatment before, if your fertility tests show that your ovaries would respond normally to fertility drugs, and if you and your doctor have discussed the risks of fertility assessment and pregnancy in women aged 40 years or older, which will apply to you. If your tests show that there appears to be no chance of you conceiving naturally and that IVF is the only treatment that is likely to help, you should be referred straight away for an IVF. Before you start IVF, you should be aware of a couple of things. You should both be offered tests for HIV, hepatitis B and hepatitis C in order to reduce the risk of passing these infections onto any resulting children or to other people. If you do test positive for any of them, you should be offered appropriate treatment and counselling. You should also be aware of some information about the long-term risks of IVF. More research is needed on the long-term safety for IVF. The long-term health risks to children born as a result of IVF treatment are low, but in women who have had IVF, there may be a small increased risk of developing borderline ovarian tumours in the future. Before you start IVF, your doctor should give you up-to-date information about the long-term risks. They should also limit the drugs used for ovarian stimulation and IVF treatment to the lowest effective dose and length of use. So what actually happens in IVF? Different combination of fertility drugs can be used in IVF. Your doctor should explain the benefits, risks, and side effects of each treatment and assess your risks individually before deciding which drugs to offer you. There's also a pre-treatment, so you may be offered the oral contraceptive pill or progestogen tablets before IVF. This makes it easier to time when you need to start taking fertility drugs. Taking the pill in this way does not mean you are less likely to have a baby. So the step 1 of IVF is the downregulation of the ovaries. So depending on the type of treatments you are having, you may be offered drugs called gonadotropin releasing hormone agonists to essentially switch off the egg production in your ovaries. These drugs make the ovaries more receptive to the gonadotropins, which are used later on to stimulate the ovaries into producing eggs. Downregulation is not the only method used to control your cycle in IVF. Your doctor should also explain which option would be most suitable for you. The step 2 following the downregulation is the ovarian stimulation, which involves taking hormones to help your ovaries produce more than one egg at a time. You should be offered IVF with ovarian stimulation, as this gives you a better chance of pregnancy than IVF using a natural cycle, where one egg is collected during your normal menstrual cycle without the use of hormones. You should not be offered natural cycle IVF for this reason. Gonadotrophins are used to stimulate the ovaries to produce extra eggs in IVF. These are the same drugs that may be used to produce eggs if you do not ovulate normally. You should be offered a hormone called human chorionic gonadotrophin, HCG, to help your eggs mature so that they are ready to be collected. You should be offered monitoring by ultrasound throughout your ovarian stimulation to check how your ovaries are responding and to check for signs of ovarian hyperstimulation syndrome, which may come as a risk. So following that is step 3, which is the egg collection. Your egg should be collected through a needle, guided through your vagina by an ultrasound. You should be given an injection to relieve any pain and to make you sleepy during the procedure for your own comfort. And step 4 is obtaining the sperm. So men should usually be asked to produce a sperm sample, if possible on the same day as the woman's eggs are collected. If you have a condition, such as a spinal cord injury, that prevents you from ejaculating, there are treatments that may help you. Otherwise, you may be offered surgical sperm recovery. If your sperm count is low or the sperm are of poor quality, you and your partner may be offered further procedures such as well as IVF. They are intracytoplasmic sperm injections and donor inseminations. So you have step 5, which is the fertilisation of the eggs afterward, which is once the eggs and sperm have been collected, they are mixed together and placed in an incubator. The sperm may then fertilise with some of the eggs. Any resulting embryos are kept in the incubator for up to 6 days before they are placed into the woman's womb. Step 6 is the transfer of the embryo or the embryos. Placing more than one embryo in your womb increases your chance of becoming pregnant, however, also increases the risk of multiple pregnancy. Your doctor should make sure that you're aware of this risk, and you should not have more than 2 embryos transferred at one time. The decision to transfer 1 or 2 embryos is based on your age, the quality of the embryos, and whether you've had a previous unsuccessful IVF cycle. Younger women usually have better quality embryos. This improves the chances of pregnancy. If you're using donor eggs, it should be the donor's age rather than your age that is used to help judge the embryo quality. So the table below gives you a guide on how many embryos you should have transferred based on your or your egg donor's age. So you have the age groups, which is under 37 years, between 37 and 39 years, and between 40 to 42 years, as well as the treatment cycle that you're on, which could be the first, second, or third full cycle, and how many embryos that should be transferred according to those variables. The doctor should use an ultrasound to guide the placement of the embryo into your womb. You don't need to stay in bed for long after the embryo transfer, as this has not been shown to make any difference to the chance of pregnancy, contrary to some belief. After IVF, you should be offered progesterone to help the embryo to attach inside the womb. If you have become pregnant, you don't need to take progesterone for longer than 8 weeks after the conception. So freezing embryos after IVF is another topic that must be discussed. After your embryo transfer, if there are any remaining good quality embryos, you should be offered the chance to freeze them for possible use later. An embryo that has been frozen can be thawed and transferred into your womb, either as part of your natural cycle or as part of a cycle controlled by hormone treatment. If you ovulate regularly, your chances of a successful pregnant after thawed embryo transfer are similar whether your cycle is natural or stimulated. Intracytoplasmic sperm injection, I have previously mentioned before, are recommended for some men if their sperm are not capable of fertilizing eggs in the usual way. So in this case, you and your partner may be offered a procedure called intracytoplasmic sperm injection, in which a single sperm is injected directly into an egg. You should only be offered ICSI if there are a few sperm in your semen, or if they are of poor quality, or there are no sperm in your semen either because of a blockage or another cause, but there are sperm in your testes which can be recovered surgically, or you have already tried IVF but there was poor or no fertilisation of the eggs. In these situations, ICSI increases the chance of fertilising eggs compared with IVF used on its own. However, it doesn't make any difference to whether this will lead to a successful pregnancy. If you are not able to ejaculate, it is possible to obtain your sperm using surgical sperm recovery. You should be offered the chance to freeze some of your sperm for possible use later. Before you consider ICSI, your doctor should offer both of you appropriate tests and discuss the results and their implications with you. They should also consider whether a genetic problem could be affecting the sperm production. For some men, fertility problems result from a gene defect on their Y chromosome, otherwise known as the male sex chromosome. If your doctor knows or suspects that you have a specific gene defect, they should offer you appropriate genetic counselling and tests to guide you through. If your sperm quality is very poor or you don't have sperm in your semen because of problems with sperm production, you should be offered a test known as karyotyping. This checks for abnormalities in your chromosomes, and you should be offered genetic counselling about the possible results of this test. Some couples may be recommended or may choose to look into donor treatment for various reasons. First, let's talk about donor insemination, which involves using a sperm donated by another man. As a couple, you may decide to consider donor insemination as an alternative to intracytoplasmic sperm injection, known as ICSI. Your doctor should offer you both options and explain the advantages and disadvantages that comes with each. Donor sperm can also be used for IVF if necessary. You should be offered donor insemination if there are few sperm in your semen, or if they are of low quality and you have decided against having ICSI, or in the case that you have no sperm in your semen. You may also be offered donor insemination if you have a genetic disorder that could be passed on to any children, an infectious disease that could be passed on to the woman or to any children, or if you and your partner's blood groups are not compatible. If you're considering donor insemination, you should be offered independent counselling about the implications for you and any children you may have. All potential sperm donors should also be offered independent counselling to help them think about the implications of donation for themselves, their own children, and any children that they may have as a result of donating sperm. For a woman, before you start treatment using donor insemination, you should be offered tests to confirm that you are ovulating. You should be offered tests to check your fallopian tubes if there is anything about your medical history that suggests they may be damaged. If you are ovulating regularly, you should be offered at least 6 cycles of donor insemination. To reduce the risk of multiple pregnancy, you should be offered unstimulated insemination, which means that you're not given any fertility drugs to stimulate your ovaries during treatment. You should have intrauterine insemination rather than intracervical insemination, as this gives you a higher chance of becoming pregnant. If you have not become pregnant after 3 cycles of donor insemination, you should be offered tests to check your fallopian tubes if they have not been done earlier. Since you have sperm donation, you also have egg donation. Some women cannot produce eggs, usually because their ovaries are not functioning or they have been removed. If you are in this situation, you may wish to consider receiving egg donation, that is using another woman's eggs to get pregnant. You should be offered this option if your ovaries have stopped working early, if they've stopped working due to chemotherapy or radiotherapy, if you have chromosome abnormalities such as Turner syndrome, or if your ovaries have been removed. You may also be offered this option if you have not had success with IVF or there is a high risk of passing on a genetic disorder to your children. If you're considering receiving egg donation, you should be offered independent counselling to talk over what the treatment will mean for you, any children you already have, and any children you might have as a result of the treatment. On the other hand, if you are considering donating your eggs, your doctor should offer you information on the risks associated with ovarian stimulation and egg collection. All potential egg donors should be offered the chance to see an independent counsellor to help them think about the implications of donation for themselves, their own children, and any children they may have as a result of donation. Occasionally, a woman having fertility treatment can choose to donate some of her eggs in return for a benefit such as discounted IVF. Her eggs are then donated to a woman who is unable to produce her own eggs, sometimes referred to as egg sharing. Anyone who is considering taking part in such a scheme should be offered the chance to see an independent counsellor as well to talk over what it will mean for them. You may have already heard of the terms freezing sperm and/or eggs, so if you'd like to know what that entails, please keep listening. So sperm, eggs or embryos can be frozen and stored for possible use in the future. This is known as cryopreservation. So egg freezing. You may have already heard of the term freezing eggs and sperm, but you may not know what that entails and why it's done. So this is what we'll discuss now. Firstly, we'll be talking about the freezing of eggs and sperm or embryos before cancer treatment. So sperm, eggs or embryos can be frozen and stored for possible use in the future before cancer treatment, known as cryopreservation. Cryopreservation of sperm, eggs or embryos may be a possible option for people who have been diagnosed with cancer if the cancer treatment is likely to cause infertility. If you are diagnosed with cancer, you should be given the opportunity to discuss your diagnosis and the effect of cancer treatment on your fertility, both with your cancer team and with a fertility specialist. The decision to freeze some sperm, eggs or embryos depends on several things, including the type of cancer you have, your treatment plan, and how quickly your treatment needs to begin. Your healthcare team should also take into account whether future fertility treatment is likely to be successful and whether the stored sample will still be usable when you're likely to need it. You should be able to have your frozen sample stored for at least 10 years. So the criteria for having fertility treatment that have been described throughout this information do not apply to people who have been diagnosed with cancer and wish to use cryopreservation to preserve their fertility. However, if you need to use your frozen sample in the future, these criteria will apply if you are having your treatment in the NHS. So let's talk about freezing sperm first. So if you're a man or adolescent boy, you should be able to have a sperm sample frozen before your cancer treatment begins. Storage of your sperm should continue beyond 10 years if you are still at risk of fertility problems after this time. So when it comes to eggs and embryos, on the other hand, women and adolescent girls, if appropriate, who are well enough to have ovarian stimulation and egg collection should be offered either egg or embryo storage, depending on which is most suitable before their treatment begins. You and your healthcare team should discuss whether there is enough time to have this procedure before your cancer treatment needs to start. So the egg collection process can take several weeks for reference, so taking into account whether it may worsen your condition or outlook. So there's a few questions that you might want to ask your fertility specialist or counsellor or any other team that you're dealing with during your fertility process. So these questions may help you discuss your condition or the treatments you have been offered with your healthcare team. Can you explain more about how my age affects my fertility? Are there any useful national or local support organisations I could contact about my fertility problems? Can you provide some written information for me about fertility problems and their treatment? What fertility treatment might I be able to have on the NHS? How do I face the uncertain future and make a plan for the outcome of my fertility treatment, whether that's by having a child or accepting that I won't? When and where can these fertility tests be carried out, and how long does it take to get the results? Can we still conceive naturally despite a low sperm count? Can you explain more about the different tests for examining the fallopian tubes and which one I will need? What happens next if no problems are found in our fertility tests that you recommended? Can you tell me why you have decided to offer me this particular type of treatment? What are the pros and cons of this treatment? What will it involve? Are there any risks associated with this treatment? What are my options for taking treatments other than the one that you have offered me? Is there some other information, like a leaflet, DVD, or a website that I can go to about the treatment that I can have? I am unable to ejaculate. Can you explain the treatment options available to help me? I have an ovulation disorder. Can you explain which type of ovulation induction treatment would be most suitable for me? What are my chances of having a multiple pregnancy with this treatment? Can you explain more about the laparoscopic ovarian drilling and whether this may help me? If I have endometriosis, can I still conceive naturally? What are the treatment options to help me with this? Is there any treatment we can try for unexplained infertility? If the man's sperm count is low, would IUI help us to conceive? And can you explain more about the procedures involved in using donor sperm for IUI? What are my chances of having a baby through IVF? Can you explain more about the relative merits of using ICSI or donor insemination? Can you tell me more about the risks of fertility treatment and pregnancy in women aged over 40? How many embryos should I have transferred? Can you explain more about the risks of multiple pregnancy? Can you give me more information about the long-term risks of IVF? Can you give me some other information, like a leaflet, DVD, or a website that I can go to about IVF? If IVF doesn't work, can we choose to try IVF with ICSI? Are there any long-term safety risks of using ICSI? Should I delay my cancer treatment long enough to have my eggs or embryos collected for cryopreservation? If I do not have my eggs or embryos collected, what are my likely options in the future of having children? Will having my eggs collected make my illness worse? So it's important to ask these questions in order to gain a better understanding and a better insight into your own health about your fertility. So next we'll be looking at some of the terms that you may not understand, and we will be explaining what they mean. So artificial insemination is a procedure that involves directly inserting sperm into a woman's womb or cervix, which is the neck of the womb, to help her conceive. When we talk about assisted reproduction, we talk about treatments that enable people to conceive without having sexual intercourse. Methods include intrauterine insemination, IUI, in vitro fertilisation, IVF, intracytoplasmic sperm injection, ICSI, donor insemination, and egg donation. So body mass index, or BMI, is a term that gets thrown around a lot in all aspects of healthcare. It's the measurement used to define the range of healthy weight. Your BMI is calculated by dividing your weight in kilograms by your height in meters squared. That is your height in meters multiplied by itself. A chromosome is a thread-like structure found in cells that contain a person's genetic information in the form of genes. When we talk about cycles, we're usually referencing IVF, a single course of treatment. In IVF, a full cycle is one in which embryos produce sperms. So when we reference cycle, we usually refer to IVF, and by that we mean a single course of treatment. In IVF, a full cycle is one in which embryos produced from eggs collected after ovarian stimulation are replaced into the womb within a few days of their formation, with any remaining good quality embryos frozen for use later. When these frozen embryos are used later, this is still considered to be part of the same cycle. An egg is essentially the female reproductive cell. A woman usually produces one egg in a normal monthly cycle. An embryo is this egg which is fertilized. A fallopian tube, or fallopian tubes, are the pair of tubes leading from a woman's ovaries to her womb. The fallopian tube is where the fertilization of the egg by a sperm takes place in natural conception. When we refer to follicles, we mean a small sac in the ovary in which the egg develops. And gonadotrophins are hormones that a woman can take to stimulate her ovaries to produce eggs. They can be given during ovulation induction and ovarian stimulation. In men, they can be used to stimulate sperm production. IVF stands for in vitro fertilisation, which is a technique by which eggs are collected from a woman and fertilised outside of her body. One or two of the embryos created are then transferred to the womb, and if one of them attaches successfully, it results in a pregnancy. Intracervical insemination is a procedure in which sperm is placed into a woman's cervix, which is the neck of the womb, to help her conceive. We also have intrauterine insemination, which is a procedure in which sperm is placed inside a woman's womb to help her conceive. A laparoscopy is a routine keyhole operation done under general anaesthetic, in which the surgeon uses a very small telescopic instrument, a laparoscope, to examine or operate on an area in a woman's pelvis. When we refer to multiple pregnancies, we are talking about a pregnancy in which the woman is carrying more than one baby. Multiple pregnancies carry higher health risks for both the mother and the babies. Ovarian stimulation is the use of gonadotrophins to stimulate the ovaries to produce more than one egg at once as part of IVF treatment. And this may come with ovarian hyperstimulation syndrome as a risk, which is a potential serious condition that occurs when the ovaries overreact to fertility drugs. When we talk about the ovaries, in this case we're talking about two small organs in a woman's reproductive system which produces follicles and eggs. And ovulation is a process by which the ovaries produce eggs. In a woman's natural cycle, ovulation occurs when a mature egg is released from the ovary each month. Ovulation induction is the use of fertility drugs to control or stimulate a woman's ovulation. Semen is a fluid containing sperm that is produced by a man during ejaculation. And sperm is the male reproductive cell which fertilizes a woman's egg. Come across the term surgical sperm recovery. This is a minor surgical procedure to obtain sperm from the testicles in men who cannot ejaculate or have a blockage in the flow of sperm from their testicles. An ultrasound scan is used in many procedures, which uses a high-frequency sound wave to produce images of the internal organs. If you are seeking any advice and support or have any queries, please refer to these great free resources that we have linked below, such as Cancer Research UK and Fertility Friends, as well as Stonewall, Terence Higgins Trust, etc. You can also go to the NHS Choices or the Human Fertilisation and Embryology Authority website for more information about fertility problems. Please be aware that NICE is not responsible for the quality or accuracy of any information or advice provided by these organisations. Thank you so much for your time. This is Fertility Connected, and we hope that you've enjoyed this presentation.